Good morning, everybody. It's Dr. Gillard here. This is our last lecture in spinal anatomy. Again, sorry, couldn't be there in person, but the coronavirus is wreaking havoc throughout the world. So, all us professors are forced to go online, which, I do these things anyway, so not that big a deal, but it's always better to be there in person. So, apologize for that. So it's not too long of a lecture today. This is about the basics of biomechanics, specifically talking about a motion segment. Let me get my little pointer up here. There we go. So we should be able to get through this pretty quick. This will be on the final exam next week. Remember, your final exams will be held at exactly the same time as usual. They'll just be done online. Biomechanical planes of motion, the basics. So a true spine expert, we're true spine experts, right? You got to understand some biomechanics. Yeah, you got to. So clinically, once you get into clinic, you kind of forget these biomechanics, but if you're going to read papers and things like that, or maybe even work in research, you got to understand the normal biomechanics. Clinically speaking, this is all we usually use. Flexion is going forward, extension is going backwards, lateral bending or side bending, you have left and right lateral bending, and rotation is just twisting. And these are lumbar ranges of motion, right? Basically the same for the cervical. Thoracics can be a little bit different. Well, actually, the same range of motion. There's same motions for thoracic too. They're just measured with this little. Well, we won't get into that. So there are only two types. It looks easy, right? There's only really two types of motion that a vertebrae can go through, and that's something called translation. That's a little foreign to some of you, maybe. That's sliding. If you take a block, like a kid's block, you put it on a table and you slide it. That's translation. That's a translation. It's sliding along an x-axis in that case. But there's three axes that we'll talk about. But think of it as a sliding motion. And then there's rotation, and we know what that is. That's just twisting. But it's twisting around a given axis, one of the XYZ axes. So yeah, but unfortunately it's not quite that simple. But really, those are the two motions, and there's different types of those motions. So translational motion, let's talk about that. So it's defined as, it occurs when a force pushes a block. There's our block sliding across the table, or a vertebrae, right? Translation, anterior translation. If you bend forward, this motion occurs. But it's when a force pushes on a vertebrae, because there's a force pushing the vertebrae, started with these dotted lines, and all the points on the vertebrae move in the same direction. So you can pick any point you want in this block, and when the force pushes it forward, if all those points go in the same direction and in the same plane, you have a translational movement. Pretty good with that. So let's call it a translational movement. There can be no spinning of this block. It's got to be straight movement forward. All the points go the same. You could go a step further. If this is on a surface like our block on the table, there's a force created on the table, and that's called a shear force. So vertebrae do create shear upon the intervertebral disc and other parts of the vertebrae. Pretty good with that? So in this example, we started with the block in this dotted configuration. A force was imparted on the block, and it slid forward. It's actually slid forward 5 millimeters, since all the points moved in the same direction and in that same horizontal plane, we could say. This is a translational movement. It's just sliding. We're just sliding something. Okay, now rotation. And this is coming from Bogduke, of course, which is, he's my favorite, and he's considered the god of the lumbar spine by some. Very famous guy. So a lot of this is coming from his book. a little bit from Kramer, but mostly from Bogduke, which is a chiropractic board of examiner's book, right? So you could be tested on this stuff on boards. So now rotation, what's the deal with rotation? That occurs when at least two forces act on a vertebrae, but the key is they have to act at different points on the vertebrae. So here's the dotted configuration, is where our block started. We imparted one force here, and then we imparted another force over here at the corner, and it caused a spinning of that vertebrae. That's called a rotational movement. Okay, rotational movement. If we go back to this one, what if we put two forces, one up here, three forces, one here and one down here? Oh, I can try, let me try out my drawing tool. Hang on. So what if I put a force like this, and another force down here like this, and then we have this force. So are we going to get a rotation from that? There's three forces. No, they're all in the same direction, and all these points would move in the same direction. So it's still considered a translational motion. Okay? Points at different distances, note that these points this time, they don't move in the same plane, and they move different distances. The further away you are from the center of rotation here, the further you will move. And this movement is called an arc. Arc. So points at different distances from the center will move at different amounts. Each movement is called an arc. Rotational movement occurs around a fixed point in the very center of the axis of rotation, and there's no movement of that point. So that's how you find the center of rotation. That point will have no movement. Rotation, what causes it? Well, you could say that, here's the word coupling, you could say that forces are coupled that cause rotation. So if you add this force to this force, those forces are coupled and that causes rotation. Okay, notice that the coupled forces cause a vertebral body to rotate around a fixed point. That's the blue point here. That blue point is called the center, I think I said that, the center of rotation. Torque, we're not going to go crazy on that, but the net force, or the net force from the coupling forces is called torque. And I think we cut some slides out there. I don't think they can teach that in upper quarters if they want to get into torque. Okay. Oh, I guess I didn't cut all the slides. Torque may be the result of two opposing forces, both generated by different muscular actions. So two different muscles can generate a torque. It may be the result of one force and one resistance. So a muscle and a ligament force on a muscle can also generate torque. Gravity can be a force opposed by a muscular action or ligamentous resistance, and that can be torque. For example, your cheeks on your face are held up against the force, gravity, and that creates a torque. I thought I took that slide out, but I guess I did leave some more in. When a bone rotates, so here's a bone. Let's say this is your humerus. So let's twist the humerus. When a bone rotates, we say that different points have different rotational excursions. So these arcs have different excursions based on where the point is what we're saying here. If there's a point here, the arc or the excursion of that point is not going to be very great. If we put a point way out here, the excursion is going to be quite great. Okay, but the other concept, even though these points have different excursions, they all rotate in the same plane. So that's the key there. Alright, so the axis of rotation, let's try this one again. So let's pretend this is your humerus. When your humerus rotates, there'll be one point. You could stick kind of a spear down the humerus where there'll be no excursion or no arc. That would be the center, the axis of rotation. Definition, the region in a bone that does not move when two or more opposing unaligned forces act on it and cause a rotation. So in other words, there's multiple centers of rotation, but you could stick a stick through them, and that would be the axis of rotation. The axis of rotation will always be perpendicular to the plane of rotation. So here's the stick. This is the dead center point where when you rotate the bone, there's no arc created. It's right in the center. And that's the axis of rotation. But notice that the plane, or the plane of rotation, or the plane here, is perpendicular. It's 90 degrees to the axis of rotation. So axis of rotation will be perpendicular to the plane of rotation. Okay, we said the line is called the axis of rotation. No net force is acting on the center of rotation. All right, planes of movement. Biomechanical planes of movement. So movement generally occurs in several opposing directions. You have forwards versus backwards flexion or extensions. You have right side bending to the left side bending. You have a distraction upward or a compression downward. You have twisting to the left, twisting to the right. How are we going to describe these in biomechanical speak? Well, in order to really describe planes of motion, we have to have an axis for those motions to go around. And if you go back to your old high school days, or probably junior high days, junior high, maybe even grade school these days, you're taught there's three axes. And they are basically the X, the Y, and the Z axis. I'm sure everybody knows the X and Y. The Z axis may be a little not so known to people, but it's a very important one. Okay, so those are called the three biomechanical axes, X, Y, and Z. Be a nice question, wouldn't it? Which one of the following is not one of the three biomechanical axes? I could say the W, the X, the Y, the Z. That would be a really ridiculously easy question. All right, so let's look at the old cube. Go back to geometry days. So this is the purple. You got to use your mind now because this is two-dimensional. The purple is coming out of the plane of the page. Right? This lateral one, left lateral, is going into the plane of the page deeper and deeper. There's the anterior, would be deep into the plane of the page. It's cut off because we can't see it all. Can't see the right lateral side. There's the inferior side. The superior side would be behind the posterior up here. So here's our three biomechanical axes. So the X1 would run medial to lateral for the center of this block. The Z-axis would go deep into the plane of the page, and in this block it would go in a posterior to anterior direction. Going straight up, inferior to superior by these arrowheads, that's the Y-plane. All right? Simple as that. I think you know that. If we draw, let me try my drawing tools again. This is a pretty cool little program. So if we draw a little human here, and now you will learn why I don't draw on the board, and I like my PowerPoints. Okay, here's a human just sticking out like this. So if you stand like this and put your arms straight out, like pretending you're an airplane, what plane is this? I think I can actually change colors with this little program. Oh, look at that. What plane is that? Well, it's going medial to lateral. Medial to lateral. So that's the x-axis. X-axis. How about if we draw a plane going like this? Up and down. Like your spine is in which axis? Well, this is inferior, superior, right? Yeah, so that's the y-axis. Now this one's hard to draw from this angle, but it would be coming straight out of the plane of the page at us. I can't draw three-dimensionally, but that would be the z-axis, right? Because it's coming posterior to anterior. Got it? All right. Now if we apply those forces to a vertebral body, pretty simple. There's our arm. If we're back to that same drawing, if we're standing up straight and sticking our arms straight out. The transverse processes, this lumbar vertebrae, are like the arms. So that would be the x-axis, right? And then the spine or the spinal cord would be running straight up and down. That would be the y-axis. And then going straight forward out of your belly button, heading straight forward, straight anterior, posterior to anterior, or you could say anterior to posterior, it doesn't matter, it's the same axis. That's the z-axis. Everybody good with that? Important concept to know. All right, as we mentioned before, there's only two types of biomechanical motion. You have translations, which is just sliding, and rotations, which is twisting. Okay, we already covered that. So transitions are sliding movements, but they have to be around one of the planes. So they're going to go down one of the planes, either the X, Y, or Z. Some people think it use the word gliding motion. It's the same thing. But it's not going to be twisting around. You can't translate around one of the axes. You would be crashing into one of the other planes if you did that. So this has got to be a sliding motion. Rotations are spinning around one of these planes. Okay? I think that's pretty intuitive. So anterior, posterior, here's our first one. So let the start, I mean, these are all important. You're going to get tested on these here and on boards. So you have sagittal translation. So sagittal plane, what's the sagittal plane? So here's our little man here. Here's his nose. Here's his eye. All right, there's our little stick man. So we're looking at this guy from the side, right? Again, this is why I don't draw. But this is a sagittal plane. So we're observing these movements in the sagittal plane. So if we have an anterior posterior sagittal, that means you're observing from the side. Translation means a sliding. So we're talking about a sliding motion this way or a sliding motion that way. And who are we talking about? We're talking about these vertebral bodies in here. So that's all it is, an anterior sagittal translation. And we know what's the axis that comes straight forward. That's the z-axis. Okay, so an anterior sagittal translation is a sliding straight forward of the vertebrae. Or a posterior sagittal translation is a posterior sliding of the vertebrae. Okay, and that's got to be along the z-axis. Everybody see how that works? And again, sometimes you call it sliding, some authors call it gliding. But okay, we got that. All right, so let me get a little sip of water here. So try to figure out what that is. Well, that's sagittal translation. We just talked about it. But now we're going back to our bone. So anterior sagittal translation is sliding forward. These are clinically important motions here because you can have instability with these. Posterior sagittal translation. But how does sagittal fit into this? Sagittal means you're observing from the side, from a side view. We can observe from a horizontal view, an overhead view, an axial view, if you will. Transitional view, cross-sectional view, chat, right? Or we can observe from a front, from a coronal plane. But right now we're observing from the sagittal, from the side. So you can have an excessive sagittal translational movement, and that creates a instability and maybe a cause of chronic back pain. We'll look at an example of that. I think I've showed you an example of that. How does sagittal translation occur in the spine? Well, it's coupled with another motion. So in order to have a sagittal translation, you have to bend forward or bend backwards. So it's said to be coupled with sagittal anterior or sagittal posterior rotation. So those are coupled together. So forward or backward bending in a motion segment is called sagittal rotation. And that's what causes the bone to try to move forward and try to move backwards. So these two motions, we should have more stars here. It's an important concept that these two are coupled together. Got it? So these two sagittal, we're observing sagittally from the side. So sagittal bending and sagittal translation are coupled together. Well, they're coupled together, but really it's the sagittal rotation that causes the forward, or causes the sagittal translation. Everybody good with that? Think about that. What about sagittal translational instability? So normally when you bend forward, the bone wants to slide forward as well. Okay, so normally that doesn't happen, does it? Might happen a tiny bit, but it should never happen more than 3.5 millimeters. So if you bend forward and backwards, you have your facet joints, or in our class we're calling them zygapophyseal joints or Z joints. When you get into the real world, nobody calls them that. They all call them facet joints. So you have a neural arch that's intact. All of that stops anterior and posterior sagittal translation. But what if you have a crack in the pars interarticularis? Or what if you have sagittally orientated degenerative facets that don't work anymore? You can actually get abnormal translational movement, anterior posterior translational movement, and that can be a source of pain. It can jam into the traversing nerve roots and cause sciatica. So anything greater than 3.5 millimeters is the standard that we all use. That's considered an instability, specifically a anterior posterior sagittal translational instability, if you want to get specific about that. All right, so here's the concept. So if you take a motion segment and here's kind of the ghost view where you started. If you flex that motion segment forward, normally these two dots in the posterior corners will stay in place. There'll be no anterior slide here, no anterior or sagittal anterior translation. But in people with a fracture let's say they have a fracture through the pars interarticularis, or the facets are rotten and they don't prevent slip, when you bend forward, you will actually get some movement. So in this vertebrae, you can see that when they bent it forward in the lab, it actually did translate forward. There was some anterior sagittal translation forward. In fact, there's ways to measure that. And if it's over 3.5, that's a problem. Surgeons aren't happy if it goes 3 or 4. Surgeons don't get excited. It goes over 5 millimeters, 7 millimeters. That's definitely cause of chronic pain in most people. So fusion will be needed to fix that abnormal motion. Okay. So in this case, 7 millimeters of anterior sagittal translational slip has occurred, and that's instability. This patient's unstable. That's why your flexion extension radiographs are super important, as are your lateral bending radiographs. Let's do a case. A 52-year-old female from India with chronic low back pain consulted me, and she was told that she was not a surgical candidate. Miserable, absolutely miserable. Her Oswestry Disability Index was 55%, just miserable. So the first thing I asked is, well, did they do a flexion extension x-ray? How do you know you're stable? Well, they didn't do that, so we ordered one. Here's the flexion extension that we ordered. So she does have a spondylolisthesis at L5. So when she bent backwards, So this is a little, because you don't, when you're unstable, you don't always follow the rules. Normally when you bend backwards you slip back, but in this case it was the opposite. But nevertheless, when she bent backwards, you can measure the S1 back of the S1 segment to the posterior inferior corner of L5, and we can draw a line there, and we got 0.85 centimeters. When she flexed forward, instead of normally translating forward, she went backwards. So she almost went back to zero. So not good, right? So you can convert these 8.5 centimeters is of course 0.85 centimeters is 8.5 millimeters. So 8.5 millimeters minus 1.6 millimeters, because it didn't go all the way back to zero. So she's got almost 7 millimeters of sloppiness, slipping and sliding in the sagittal plane. So she's got anterior posterior sagittal translational instability. Usually we just call that she's got translational instability. They just assume they get too lazy when they report in the literature. They'll just say anterior posterior translational instability. But technically it's sagittal anterior posterior sagittal instability. She's slipping and sliding around and jamming her nerve roots. That's why she had the sciatica. Facet joints are irritated. The fracture and the pars is irritated because she's slipping and sliding around when she's doing the normal activities of daily living. So source of chronic pain. So yeah, she had 7 millimeters of sagittal translational movement. She underwent a successful T-lift procedure, and she didn't get perfect, but she did really good for such a surgery, 22%. So that's about par for the course. Everybody doesn't get like Tiger Woods does. We'll see how Tiger Woods does in another 5 to 10 years after really testing that fusion construct. But anyway, yeah. So that's an active example of how translational instability can cause problems. Okay, now this is confusing. What about horizontal translation? What the heck does that mean? Well, the first part always tells you where you're going to be observing from. So in a horizontal, that's the hat, right? Horizontal, axial, transverse, cross-sectional. You're going to be looking from either underneath, or it's easier to think of you're looking down, a bird's eye view. Okay, so translation, if you're looking down, how can a vertebrae translate? Gosh, I'm going to try to draw this. I'm probably going to be sorry I did this. Here's a vertebrae from a bird's eye view, right? Spinous. Oh my god, that's terrible. Let's try that again. Here's the vertebral body. Here's pedicles. Here's the vertebral arch. And I'm trying to draw my finger too. It's not like I have a pencil here. See, I'm trying to make excuses. Alright, there's a vertebrae. Alright, but we're looking down on top of it. So horizontal, we're looking down at it. Now translation. Well, I mean, it really can't go forward because the facets lock it, but it can do this. I mean, you just have to memorize these things because that's what's so confusing about biomechanics. So when we say horizontal translation, we're looking for side to side slip in a flat plane. Is the point I'm trying to make here. Why it's confusing? Because I mean, we could actually see front and back slip as well. So that's why you just have to memorize anterior and posterior sagittal translation is always looked at from the sagittal plane. Lateral slip, lateral translation, slipping like this is always observed from the horizontal plane. There's no rhyme nor reason to that really. You just have to memorize that. Okay, get rid of that thing. So we have a left and right horizontal translation. That means that the vertebrae sliding to the left or it's sliding to the right. It's in relationship to the vertebrae below as you observe from above. The movement is viewed from an overhead perspective, so that's a horizontal or axial. And we're going to get in trouble with this. We're not going to, but biomechanics are going to get in trouble with that word later on. But in biomechanical speak, it translates around what axis? That would be well, we saw the little transverse processes show you the x-axis. So the translation or the slide is along the x-axis. If you're a real nerdy biomechanist, you can say if it slides to the left, that's designated as x plus. If it slides to the right, is x minus. Okay, so left horizontal translation is nothing more than left lateral slide. Another way you could say it. Right horizontal translation is right lateral slide. Hey, there's a picture of that. Only we're kind of cheating, right? We should really be looking from overhead view, but nevertheless, that's a horizontal translation, kind of from an overhead oblique type view. But it slides, bottom line is it slides like that along the x-axis, right? What about horizontal translational instability? Can you have a kind of a lateral instability? And you can. So some people can have a horizontal translational instability along the x-axis. About that same 3.5 millimeter rule kind of applies. In reality, go into the PubMed and type in horizontal translational instability. I don't think you'll find a single thing. I googled it. There's very, very few people who actually call it that. They call it lateral translational instability. So you have AP translational instability, means you have an abnormal slip going front and back. Lateral translational instability is a lateral slip, which is a little unusual, right? And there's some coupling involved with that. We're not going to get into that. They can teach you that in upper quarters, but nobody calls it that. But I will for the test, right? For biomechanics, you need to know what this horizontal translational instability is, and it's too much slip, greater than 3.5 millimeters of slip when you laterally bend to the left and laterally bend to the right. Where do you see this horizontal translational or lateral translational instability? Scoliosis patients. Scoliosis patients, we've talked about a spondylolisthesis or an anterolisthesis. We haven't talked much about a lateral listhesis, and people with scoliosis can have a slip laterally, and it can compress nerve roots and cause horrible radicular pain. Right? 24-year-old patient, chronic back, thoracic spine pain. What do you think there? Did an Adams test on her. You'd see hunching like crazy in here. Shoulders are a little bit unlevel, but you can see there's the rector spinae muscles are really twisted. Let's take a look and see what she looks like on an x-ray. Holy smokes. Right? So wicked, was that Linky 5? Go to my Linky videos and I'll teach you how to medically classify scoliosis. It's a bad, pretty thoracolumbar scoliosis though, right? Can you fix something like that? It causes horrible debilitating pain? Yep. So you can fix it posteriorly. This is an anterior intersegmental fixation. It's weird they call it anterior because it's done, you can see the surgical staples. It's done through the side, and they put pedicle screws in. I guess they don't call them pedicle screws, but they put them through the vertebral bodies. Why is it called anterior fixation? Because it's going through the vertebral bodies and not, which is the anterior column. Right? It's not going through the posterior column, but they fixed it, right? Got some videos on that. So let's do a real case. 55-year-old male patient comes in disabling low back pain, which was recalcitrant to conservative. What's that word mean? Recalcitrant. What's refractory mean? Those are two words you need to know. It means it was resistant to care. It didn't need treatment. Chiropractic, physical therapy, acupuncture didn't work. Even the pain management docs, the needle docs couldn't fix him. So then they go to the surgeon. So he consulted with me, brought in an MRI disc. What do you think of this? This is an A to P view, coronal view. Some of you are seeing the problem, right? So look at the corners here. There's the corner of L4. Get my drawing tools out here. There's the corner of L4. Whoa, there's the corner of L3. That's no good, right? Right? We got a slip. We got a lateral translation that's not supposed to be there. The question is whether or not that's unstable. If you order flexion lateral bending films, have the patient bend each way, maybe it'll slide back to the neutral here, and then you bend over to the left, maybe it slides way over here. Okay, so you can have a instability in this lateral plane as well. That's the point there. Okay. Yep, everything I said right there. Okay, in clinical practice, you call that a lateral listhesis, and you have to do lateral bending radiographs to see if they have lateral translational instability. Okay, and I mean, for biomechanics, do they have horizontal translational instability? That's just, I mean, you have to memorize that, and it's just, I mean, practically, you forget that stuff. So if you say lateral translational means slip, instability, you think, oh, okay, so the spine, the vertebrae are slipping lateral, medial to lateral. Makes more sense. But nevertheless, this is Biomechanics Day. We're going to use biomechanics. Okay, coronal translation. What the heck is that? Coronal view is looking straight at the patient from an A to B view. And so translation is a slip. And so what could this be? This is where it's confusing. You just have to memorize it, because in a coronal view, I mean, if we're looking at coronally, we can see the blocks. There's two vertebrae, A to P view, right? Spinuses are in the back, or we could do the spinuses here. Coronal view, I mean, what could we see? We could see lateral slip, right? But they don't, for whatever reason, they use coronal translation to mean any kind of a slip or movement upwards or a slip downwards. These are not, you don't see these in clinical practice, but that's what coronal means. So for a coronal view, we're just looking for a cephalad coronal translation, and this is all around what's the rod going up and down. What axis is that? Good, that's the y-axis. What axis is this? Transverse processes would be sticking out here. Hold your arms out like an airplane wing. Those are the x-axes. So we're looking for upward slip, which is upward, we know from embryology. Cephalad and caudal is down toward the tail. So an upward slip in a translation, upward coronal translation means a movement of the vertebrae up, not natural. But what if you're doing traction on someone's neck and you're pulling their neck up? That's an example of cephalad coronal translation. So it comes in more like to a treatment type of deal. All right, so you just got to memorize that. So from the coronal plane, we're just looking at up and down for now. Okay, cephalad coronal translation is commonly known, more intuitively known as axial distraction. This is where it gets really confusing, because axial, terrible word to use because that's really an overhead view. Nevertheless, they're talking about the axis, the spine, like a stick going right through the spine. That's your axis. So cephalad coronal translation is commonly known as longitudinal distraction or axial distraction. Kind of pulling up the head would be an example. Often used in chiropractic techniques like the modality traction. Cephalad coronal translation is no longer used. It's been replaced by the word cephalad axial translation or axial distraction. Right? Coxflexion distraction treatment is an example of this. You'll learn that as you go through the program. What about caudal coronal translation? That's the movement of vertebrae inferiorly, how would you get a vertebrae to move inferiorly? Well, you'd push down on the head and compress it. There's some tests you're going to learn about compressing down. So that would be a movement of vertebrae down the y-axis. This term is really not used except by hardcore biomechanists working in the lab. It was replaced by caudal axial translation. So the coronal was kicked out and replaced by axial, which makes it really confusing because axial is an overhead view and you really can't see this upward and down movement. So I don't know who thought this up, but not a great idea. Makes things really confusing. This type of movement is really called axial compression, and it really has no use except for guys working in the lab. So here is cephalad coronal translation along the y-axis, caudal coronal translation along the y-axis. We're not done yet. What about rotation? How are we going to see twisting of the vertebrae to the left and right? We're going to go back to the sagittal plane. Oh no, I'm sorry. Sagittal rotation we're going to talk about first. We talked about this coupling. What was it? Sagittal rotation couples with what? It causes what motion? Anterior posterior sagittal translation. That's the kind of stuff you need to know. So we have an anterior and posterior sagittal rotation we talked about. It's a movement. Now rotation is not a sliding, it's a rotation. So it's a twisting around what axis? It's a twisting around the x-axis. Right? Those are your transverse processes. So anterior sagittal rotation is a forward bending or reflection. Posterior sagittal rotation, AKAs, are backwards bending or extension. And again, we said this movement is coupled. Actually, it creates sagittal translation, so the two are coupled together. But this is the instigating motion. So bend forward at the waist, fancy way to say that is anterior sagittal translation. And you can see how it rotates around the x-axis. Could it rotate around the z-axis? No. No way. You'd have to break the pole. You can't break the pole. You have to twist around the pole. Got it? Extensions, posterior sagittal rotation, commonly known as backwards bending. Pretty straightforward there. Now let's go back to that A to P view in the front. So now this is where lateral bending comes in. So we observe lateral bending by looking at the front plane. Okay, so we have right and left lateral bending. So what is that in biomechanical speak? Coronal rotation. So we have a left and right coronal rotation. Got it? So rotations are twisting around an axis. What axis do we have that we can twist around? Well, let's draw vertebrae. Okay, so we're looking A to P. These are the transverse processes. There's the spinous process. The back. Let's draw the pedicles in there. Right, when you're reading pathology, you always look for the man. Look for the two eyes and the nose to make sure there's no cancer. Anyway, I digress. So left and right coronal rotation. So how can we stick a stick through this and not break the stick? And because we're going to rotate it, right? We're going to rotate it this way. We're going to rotate this vertebrae this way or tip it this way. Well, there's only one stick that you can do this at. That would be a stick coming right out of the plane of the page, right toward us. And that would be the z-axis. Okay? So now we know right and left coronal rotation. This one is also coupled with horizontal translation. So remember I say you test lateral instability by doing lateral bending radiographs. So if you bend a patient to the left and to the right, that will also stimulate a slip or translation to the right and left. Right? So it is coupled with right and left horizontal translation. Pretty good with that? I know this is not easy stuff. Alright, so here's our cartoon again. Probably should have just, instead of trying to draw it, let you see here. So we can laterally bend, we can twist around this z-axis without breaking the pole. We try to twist around this, and you can't twist around this. You can't twist around this. Right? You lateral bend around the z-axis. Awesome. Horizontal rotation, there's a right and left horizontal rotation as well. So now we're going back overhead and looking down. So what is this? This is just twisting. Twisting to the right and twisting to the left. So there's a right and left horizontal rotation. So we're looking using that overhead view again. Assessed from the overhead view, more commonly known as right and left axial rotation or trunk twisting. Axial rotation is now used instead of horizontal rotation. What the movement is a rotation around the x-axis. If you want to be nerdy or geeky about it, left horizontal rotation is called y plus or plus y rotation. Right horizontal rotation is called negative y rotation. Okay, so let's look at our model twisting here. The vertebrae twist. This is a counterclockwise twist. So that would be called right. We're observing from the horizontal plane, looking down, it's rotating around the y-axis. So we have right horizontal rotation, and left would be just the opposite. Pretty good with that? Okay, now we're using, so biomechanics introduced a word called axial. So this word was introduced to clarify some differences between translations and rotations in the horizontal and coronal plane. When you hear the word axial, think of some type of movement that occurs along the long axis or the y-axis of the body. I should have put in here. So it's the axial, it's just the spine. It's the y-axis. But again, it's confusing because it's an AKA for horizontal. So somebody didn't realize their AKAs, I think, when they designed this system. So yeah, the problem is axial is an AKA for horizontal, so it kind of messes things up a little. So axial rotation replaces the term horizontal rotation by some but not all biomechanics. Super confusing, I know. Now I'm just teaching you like it is, so you can argue with biomechanics about why they made such a mess. Wait till we get to fifth quarter and talk about the gastropathies. What a mess, and like 2 pages of AKAs, 2 slides of AKAs. Terrible mess. They should be ashamed of themselves for making such a mess. But anyway, digressing again. So many biomechanics are having trouble with the word horizontal rotation. They're forgetting, rotation, is it a coronal rotation? Do we look from overhead? So they just got rid of it, or they're trying to get rid of the word, and now they say right and left axial rotation, and that's twisting around the y-axis is what that means. Okay, so axial rotation still means right rotation around the long axis of the body. Basically around the y-axis. It's just twisting. All right. Axial translation replaces coronal translation. So this is confusing because these are different planes. So, true biomechanists look at coronal translation from a A to P perspective, but they called it axial translation. So biomechanics were even having more trouble with the word coronal translation. That's the sliding. I don't know why they're having trouble. I see that pretty clearly. It's harder for me to see this because if you look at an axial overhead view, how can you see movement coming up the y-axis? So it's confusing to me. But nevertheless, here's what we have. So some biomechanics are having trouble with the word coronal translation. So sliding of a vertebrae up or down the y-axis is what they did. So they decided to get rid of the word Instead, the general consensus is to use the word cephalad or caudal axial translation, which I think is terrible, but it doesn't matter what I think. So, aka axial translation is an aka for coronal translation. Got it? More confusion. Caudal versus cephalad. They didn't remember their embryology, I guess. So some biomechanics were still confused about the terms cephalad, caudal as applied to coronal translation. To overcome this, the more colloquial terms have caught on some circles. So cephalad coronal translation, which is just sliding the vertebrae up, distraction, was replaced by the word distraction. Or upward coronal translation is not really frowned upon. Distraction is really an AKA for cephalad coronal translation. Don't you love this stuff? Really easy to make test questions on this crazy stuff. How about compression? Pushing straight down on someone's head, a compression force. Well, that replaced caudal coronal translation or downward caudal translation. They didn't like that term, so they call it compression. Alrighty. What about flexion extension? So, with regard to the motion segments, we should say that biomechanics don't ever use the term flexion and extension with a motion segment. Flexion extension can be applied to the overall spine, but not the motion segment. Because flexion extension, we learned, is not a pure movement. Remember, it's coupled with anterior and posterior translation. So it's not good to say flexion of L5 on the sacrum, flexion of L4 and L5. Why? Because it's a coupled motion. So the bottom line, you should not talk about flexion extension of a motion segment. You should use anterior and posterior sagittal rotation instead of flexion and extension. Okay? Thank goodness that's all the deeper we're going to go into this. Right, we had a great quarter. We're done with the lecture. Sorry it kind of ended a little crazily, but and I have a feeling it's going to start the same way next quarter. I think we're going to be doing this online lecturing for quite some time. I'm guessing probably July or August before the dust kind of settles down from this COVID-19 coronavirus, which is crazy. All right. If you have questions, you can email me at my chirogeek.com, or you can email me at my douglas.gillard@palmer.edu. You can leave comments. I do watch my comments below this video, so I'll be there to help you. I know this is kind of a tough subject. Okay, see you around campus when the dust settles.